Good morning, everyone. Welcome to the Role of Medication Field Data in Measuring Adherence and Preventing Abuse webinar. I'm Bonnie Young, the DCH Health Information Technology Program Manager. I'd like to welcome you to our interoperability webinar. The Role of Medication Field Data in Measuring Adherence, Preventing Abuse. Interoperability is a secure use and exchange of health information. One way Georgia is leading in the interoperability effort is with the Georgia Health Information Network Clinical Viewer. The Georgia Medicaid providers can access GHIN via the Georgia Medicaid Management System known as GAMIS. The presenters today are Lynn Hood and Pamela Matthews. Lynn will provide the GHIN overview, and Pamela will provide the role of medication. Before we begin the webinar, I'd like to review a few housekeeping tips. This presentation is being recorded. If you have any questions, please submit them via the chat feature or the raise the hand feature. We will unmute the phone lines after the presentation. You might have to press *6 on your phone to unmute the line. The mission of the Department of Community Health is to provide access to affordable quality health care to Georgians through effective planning, purchasing, and oversight. DCH and Georgia Health Information Network are partnering for success by working closely to ensure that providers and caregivers can access patient health information at the point of care to optimize outcomes and reduce costs. Our GHIN and our GAMIS overview. Our Medicaid providers have the opportunity to be able to access the clinical viewer with GHIN through the GAMIS web portal. One click to log on to the Georgia Health Information Network. You can access patient information and reports. Our Medicaid providers can actually go through a training so that you can understand how to utilize Georgia Health Information Network through GAMIS. You have to go through the terms and the conditions first. You'll do that only once. It's approximately 7 different terms and conditions. Once you acknowledge and accept all the terms and the conditions, you'll have access to the GAMIS clinic. You have access to the clinical viewer through GAMIS. The link on your screen is our training video. Please feel free to access that for more detailed information. At this time, I'd like to introduce Lynn Hood. She'll provide us with the GHIN overview. Welcome to the webinar, Lynn.
Thank you so much, Bonnie. Let's move on to the next slide. So GHIN is Georgia's statewide health information exchange. We're the state designated entity for HIE. Next slide. We are dedicated to creating a healthier Georgia through the use and exchange of electronic health information. We're seeking to advance patient-centered health care, to increase efficiency, and to overall improve the health of our state's entire population. Next. I think I jumped ahead one. Back. We still need to go back.
Lynn, you have control. You can advance your slides.
Thanks, Bonnie. I'm not seeing the controls on mine. And I can't, so I keep hitting the wrong thing to go in the wrong direction.
Okay, no problem. We will advance it for you. 1 second.
Thank you. Let's run back a little bit. Now everybody sees what we're going to talk about. 2 more. Thank you. So what we do is we have a statewide electronic network. We bring together everybody from school clinics and ambulances, hospice, long-term care, government, 5 groups of the government, state government, hospitals, physicians, and have all that information. Now, we do not hold that information. Next slide. We have what is called a federated hybrid model. And so instead of holding data, we index the data so we know where it is, and in real time can pull together a comprehensive patient record that the provider can then use at the point of care. Next slide. We have two primary products and services. The first is Georgia Direct, which is a simple patient information exchange, and the second is Georgia Connected Care. Next slide. With Georgia Direct, this is a very basic data exchange. It's a free email messaging service. There are no hidden costs or anything with it, and it allows physicians and other authorized healthcare providers to securely send patient information using an online data system that's totally HIPAA compliant. We've already had almost 500,000 send and receive transactions in 2019, and we have 6,000 plus registered providers. Next slide. Our other product is Georgia Connected Care. This is a very robust integrated patient search or query-based program. It's integrated into EHR, and with it, the information flows into the EHR to put this together with current information as well as the aggregated information from throughout the system. We have almost 13,000 connected providers, and we've had almost 2 million queries this year to date. We have more than 33 million MPI records. These are individual records, which are then pulled together through the indexing system and delivered in real time. Next slide. Our connected organizations have been very strategically selected. We have 5 state agencies, including DFACS and behavioral health. We have 5 hospital and health systems. Our newest is WellStar that's just joined earlier this summer. There are 4 regional HIEs that are members that serve practitioners and physicians and other providers at hospitals in their regions. 4 care management organizations, CMOs, a couple of specialty connections, including the Georgia Partnership for Telehealth, and we're also connected to the National Exchange, which allows us to connect with the Veterans Health Administration, Department of Defense, as well as our surrounding states. Next slide. And that's a nice brief overview of GHIN. So now I'm going to introduce Pam Matthews. Pam is with GHIN. She's going to talk about the role of medication fill data. Pam?
Thank you, Lynn. Today we'll be discussing the importance of medication-filled data to patient care and the impact of the patient's adherence to taking their medication or the lack of adherence. And thank you. Ideally, we have, and I'm sure you're familiar with this, we have the circle of events. When the physician prescribes the medication to the point where the patient fills the medication, hopefully they're doing electronic prescribing so the patient doesn't actually have to take the prescription to their local favorite pharmacy. Then the patient takes the prescription, the patient returns to the physician, and then the physician actually evaluates the outcome of the patient taking the prescription. And there are several options at point number 5 where the physician can say, you know, we're going to keep the medication, the dosage, the type, the frequency as is. It's actually treating the diagnoses or the symptoms of which it was prescribed for, or it may be that the prescription is not the best choice as found out from the visit with the physician. So they may prescribe another medication. It could be the option is that, such as with antibiotics, it was only for a short-term duration. However, you may have the situation where it's a chronic situation and medication is required on an ongoing basis, such as with high blood pressure. So when the patient presents back to the physician, they will do the assessment and determine how effective that medication is in treating hypertension, for example. And they may have to evaluate the actual dosage and or the type. You may have a situation, for instance, where the dosage was a little bit high for that patient. So the patient shows up, has swelling in the ankles, as some medication for hypertension may present itself if it's too high of a dose, and they may have to adjust that dosage on the point where when the patient completes the cycle again, they present to the physician, ankle swelling is down, blood pressure is under control. Now, that is the ideal situation, and we know that ideally doesn't always work. We have reality. So this is where anywhere in this cycle, the patient becomes the variable. As you see, we can have a patient that forgets to fill the prescription, forgets to take the prescription, decides they're going to determine their own dosage that they want to take. Maybe they actually get the prescription, take one or two doses, and decides this is not for me. Sad to say, it could also be a situation where the patient feels like they cannot actually afford the medication. And for whatever reason, they don't tell the physician that. They don't feel comfortable doing that. So again, you have the same result. It could be that they never do return back to the physician. So reality is the patient is the variable throughout all of these 5 steps for it to be successful. So you can easily see, hold on one moment. Excuse me, this is my error here. I need to go back one. Let me continue on. So you can really see where the patient is really the key in terms of impacting the quality of the treatment, the outcomes of the care with the medication, and regardless of the reason why, if they do not adhere to the medication, it may actually impact their life. According to the World Health Organization, actual adherence to medication drastically impacts the direct result of a patient's treatment. And we can see with the 3rd bullet point that non-adherence can actually account for up to 50% of treatment failures and up to 25 hospitalizations. So as a result of the breakdown somewhere in that cycle that involves the patient, the result can be 25% of hospitalizations in the U.S. per year. Then everyone takes prescriptions. I think a good example is antibiotics if you have an infection of some sort. And it's okay to miss a dose. You may be on high blood pressure and you may forget to take a particular dose one time. The actual therapeutic efficiency of any drug, one must take it 80% of the time. So that's for anyone taking any drugs, and we know things happen where you may forget occasionally. But for a drug to really work, you must take it 80% of the time. So for chronic medications, it is estimated that adherence is only 50%. So you can see how that can dramatically impact the patient outcome. The scope of the problem, if we look at it from a higher level, is that we have almost 4 billion prescriptions written annually in the U.S. And then put that in perspective that out of that 4 billion, 1 out of 5 may never be filled. Then also, if you take the 4 remaining that are filled from that, they may be actually taken incorrectly, and maybe in regards to timing, dose, frequency, such as I just mentioned, that the patient may determine they don't want to take the drug, they don't like the result of it, they don't follow back up with the physician if they have an adverse effect. Regardless of the reason, it's estimated about 50% do not take their drug correctly. The CDC has done some analysis where if you look at this graph, you'll see that the most prominent reason for not taking medication is that they forgot, they ran out, they're away from home. So you're looking at, I would say, the first three are your typical excuses that really can apply to anyone. Interesting, the fourth one is trying to save money. And I think that could also equate not trying to read more into the analysis than what's presented, but maybe they don't have the money to actually take the medication. If you look at continuing on, the fifth is had side effects, and then the seventh is prescription wasn't working, or the next one did not think the prescription was needed. So that's where I call it the patient becomes the backseat driver. They may be taking the medication or attempted to take the medication, but for whatever reasons, they decide that they want to be that backseat driver, which is perfectly fine. The patient does need to be attuned to the reaction of taking a medication, but they need to go back to that circle we saw earlier where they need to report that to the physician or the clinician so appropriate treatment can be provided. So as we see with that, technology is playing a role today. And just a few minutes about technology. Technology can remove some of the excuses that we saw in the previous draft. And also what we're seeing today is that with technology, it's being introduced in incremental phases, and it's very creative in terms of its packaging, its dispensing, that makes it easier for the patient. So therefore, it can remove some of the excuses that we saw. And then combine the technology with behavioral prompts, such as on the telephone with iPhones, you can have many different apps that sends reminders, hey, it's time to take your medication. So that combination of technology with applications that change behavior or prompts the patient to take their medication can drastically impact for the positive the adherence to medication. Also, the other piece that we are starting to see is that technology is integrating with the physician and the medical record. So the physician and clinician can actually monitor from afar the maintenance of that and management of that drug taken when they're away from the office and when they're not directly in touch with that physician or the clinician. Technology, though, I just want to do a reminder, is ultimately a support tool. It's still up to the patient and their caregiver or their family to actually manage their medication. And then there's also a responsibility for the clinician as well in their management of the medication. We're seeing, as I mentioned, a lot of different technology. This is one example of the connected medication platform. You may, if you're an avid TV watcher, see a TV commercial, I think it's called Pill Pack, and it's actually providing individual doses. So again, it takes the guesswork out of, okay, do I take one pill or two pills? It's already pre-packaged, almost like a unit dosing for those who have worked in a hospital or maybe a pharmacist or a clinician. Very similar to unit dosing. It also can help children. While children shouldn't be responsible for taking their medication, these type of technology and other types of creative solutions can facilitate families who are very busy, that if the children are taking medications, it will help them. Again, I mentioned Pill Pack, mail order is becoming fast, very popular. We have organizations such as Express Scripts that makes it extremely, extremely easy. Then this is a solution intent that is actually an Atlanta-based solution. From there, there's many strategies to address non-adherence, and this is where really, it's a team effort. The clinicians as well as the physician has a role in this, not only the patient and their family. So what we do know, and this really applies not only to medication management adherence, but also to any type of treatment regime. When there is that connection between the provider and the patient and across their team, there is more likely increase of compliance and adherence with any type of treatment. That includes also medication. And they can use technology as well, but part of that underlying, while technology is great and is really helping us, it's the relationship between the physician, the clinician, and the patient and their family. There's many strategies that, again, can address non-adherence that can be applied by the clinician and by the physician and the clinic. Many times it's that care team that's promoting that. There's also other items that you need to be aware of. There could be, as we mentioned earlier, economic barriers to prescribing medication. So having the patient establish that relationship where they are free to share with them up front, hey, this prescription is a little bit more than what I can afford, and let them address it from that perspective. And then there's also other ways to address those type of disparities where information technology definitely can help, such as e-prescribing. It's that I just want to stress it's the relationship with the physician. My cursor is not moving. Okay. I apologize here, but my cursor is not, there we go. Reliant Medical Group. It's a multi-specialty group in Massachusetts, and they have actually done a lot of studies with their patient population to address how can they help reduce hypertension in their population. Now, with any type of example like this, the lesson learned is to look at what worked for them and what are the takeaways that one could apply to their practice and to their patient. It may not be something that you can take away exactly, but it definitely could spark other ideas that would work more for you. By focusing on just one diagnosis group, high blood pressure, and focusing on their patient population and looking at what they can do from technology to communication to building the relationship, they were able to improve hypertension control in their patients between 2011 and 2014 very significantly. Some of the ways they did that is looking at, if we view this slide, is some of their high-level strategies. They ensure that patient understands the benefits, and that's where I call you empowered the patient and the caregiver and their family with information. So they see cause and effect. The cause is, if I don't take the drug, I have hypertension and I do not feel well. Versus, yes, I do take the drug. It may have been the wrong dosage, but I worked with the physician. We got the correct dosage, and now I feel 100% better. Also, technology can help with delivering some of the education materials, such as the after-visit summary. But that's where I think everyone's been to the doctor or to a hospital, and they get this discharge sheet, and it's just a sheet of paper. That's where that relationship with the patient is very important, where regardless if you have that information provided to the patient, it's that one-on-one discussion of the information to make sure the patient understands the situation. Engaging the patient and the family, such as getting them to chart their blood pressure, and then once you show up, once the patient shows to the physician office, they have to engage to say, hey, what were you doing? How was your blood pressure? Let me see your results. So that's types of engagement that can occur also. Now, as I mentioned, with applications between visits, you can actually have reporting of, say, blood pressure in between visits. And actually, that could spark communication with the patient. Again, the patient knows the clinician and the caregivers are really interested in them and monitoring. Of course, lowering cost of medication, we touched on that already. There's several different ways that can be done, especially for physicians and clinicians to talk with their pharmacists to understand generics and also maybe do research to understand other sources for helping the patient pay for the medication. Minimizing medication complexity, that is really on the physician side. However, the patient and the caregiver sometimes can know their drugs much more in detail than sometimes the clinician. And they will now, with the advent of WebMD, they will go online to look at what are the adverse effects. So they may actually spawn some discussion with their physician due to that ability to have access to information. And that will help the physician and clinician to look at the prescribed drugs. Are they getting 5 drugs, for example, and 3 of the drugs could be resolved by only taking 1 drug? So those are examples of where the clinician and the patient can engage in discussions and look at how you can minimize their medication complexity. And I think we've used the high blood pressure medicine overdose with the example some causes swelling in the ankles in this presentation. Always monitor side effects and create that open discussion, especially using technology between visits to help identify early onset of a side effect that could be stopped very quickly. Again, empowering the patient and the family to show cause and effect. So once they see the impact of medications, you really have a higher propensity of patients and their family wanting the patient to be compliant with their medication. And again, we've talked about monitoring medication adherence. Now, taking a little bit of a left turn, let's talk about GHIN, Georgia Health Information Network. Ultimately, our goal is to help facilitate our GHIN members with the provision of information around the patient's medication fill history. And we do that through the query and retrieve of patient information. Now, ultimately, where we would like to be one day is to help support Georgia's PDMP, the Prescription Drug Monitoring Program. And as everyone knows, the current state statute requires providers to check the PMDP prior to prescribing certain controlled substances. So ultimately, that's where we would like to go. Where we are right now is that if you're querying a patient inside our clinical viewer, which is the connected care that Lynn referred to, you can pull the patient's CCD. And you can see where with this, you'll see medications, and there goes the circle. So with our patient, Henry Demosky, you can actually view and click on, we can in this PowerPoint, but you could click on medications, and what would come forth is all the medications that Henry is currently on. What we are doing moving forward with our value-added services, we are focused on medication management. What we have been doing, and the whole goal of that, is to provide additional functionality within the GHIN tools to support physicians and clinicians in the management and monitoring of patient medication. So where we are with this, we have reviewed several vendors that will help support this additional functionality. Right now, we have narrowed it down to Dr. First. Many of you may have heard of Dr. First already. And currently what we are doing is mapping their technology solution offering with GHIN, and we are currently mapping out what would that look like if we brought in a solution with Dr. First. How would that actually function for the end user within GHIN? The result of this work that we currently are doing will drive, of course, the final contract, and what the total cost will look like, and actually the timing of when we can actually unveil this. In terms of switching gears a little bit, preventing medication abuse, we know that many people die every day from overdose of opioids. And the Centers of Disease Control estimates that there is a significant impact of misuse of prescription narcotics, over $78 billion to be in fact. And that can be through a lot of different avenues, such as cost in the healthcare system, cost of addiction treatment, lost productivity, and then, yes, involving the criminal justice system as well. Now, what we do know is around 21 to almost 30% of patients prescribed narcotics for chronic pain will misuse them. Then from that number, 8 to 12% will actually create an addiction. They will develop an addiction. Then 4 to 6% will, from that addiction, will actually move from narcotics to more severe type of drugs such as heroin. And then 80% of those who use heroin first, we know actually started this journey through the misuse of their prescriptions. I mentioned the PDMP in Georgia. The program is an electronic database used to monitor the prescribing and dispensing of controlled substances, and it also helps eliminate duplicate prescribing and overprescribing. So it's a very quick way for the physician when they're prescribing to go in and check the PDMP and see what is happening. Is this, if it's a new patient, is it what we call a frequent flyer? They come back very frequently, and it's really too frequently that they are requesting narcotics or pain medication. Or is addition, if it's a new patient, have they really just 2 weeks ago went somewhere else to get a drug? So the PDMP and checking that can really help facilitate identifying those patients who could be setting themselves up for that long journey of abuse, to where there could be intervention very early on, such as with chronic pain management or other types of interventions to prevent the journey that they would ultimately go on. We know that beginning July 1st of 2018, physicians were required to check the PDMP. And then individuals with a DEA number must register in the PDMP as well. So you can see from this slide, it's a wide variety. It's just not the physicians, the MDs, and those who you typically think of in the hospital and the physician office setting. And so if you're interested in registration, we have the URL for additional information. So with that, I'd like to conclude the presentation and thank you for having us. And I greatly love presenting this information, and I'll open it up to any questions that you may have.
Thank you, Lynn and Pamela. We appreciate the details regarding GHAN and the role of medication. At this time, we'd like to open up the chat feature for the questions. Anyone out in our webinar land, if you're interested in asking a particular question associated with GHAN or with the medication information, please feel free to send us a chat. We will hold for one moment. Okay, everyone, we truly appreciate you taking the time to be a part of our role of medication field in measuring adherence and preventing abuse webinar today. We do have our very next webinar. It's going to be on August 28th at 11 a.m. It's entitled, How Interoperability Helps Hospitals Improve Patient Care and Care Coordination Across the Continuum of Care. we're requesting that you sign and actually register for this webinar with the link that's on the screen at this point right now. We do have a brief survey at the end of the webinar. We truly hope you will take the survey. It will help us to plan for future and also understand how this particular webinar was very effective for you. On behalf of DCH and GHEN, we want to thank you for participating in this webinar. Everyone, have a good afternoon. Thank you, Pamela and Lynn. We appreciate your time and effort.
Thanks, Bonnie.